touched almost all of the important points about how to use the REDAP, why it was developed, and the advantage of it. I think the biggest question I get from a lot of people when they start talking about the REDAP cup is they have the fear from cementing. So I always explain to them that cementing into the REDAP, it's one of the easiest things to do from cementing perspective, and also should have the best outcomes from cementing, because you're cementing into this highly porous cup. So the cement will never have a better backing into cementing into than the porous cup. Compared to any other bony structure, the cup will have an amazing connection with the cement and with your cemented poly, or you'll see the polar cups that Craig discussed, which I like using a lot. So I'll go a few cases and I'll give some tips and tricks how I use the REDAP cup and how I fix the different complications and revisions that present themselves to me. So the first case will be a case of a 64-year-old female, has a history of a toe hip arthroplasty more than a decade ago, and she comes in with a painful hip and inability to bear weight. I think the x-rays kind of talk for themselves. I'll go a few of her older x-rays before she presented to me. This is an outside hospital CT. You can start seeing the osteolysis and the loss of bone as we start going into the different images. Here on the coronal, you can see the anterior column being destroyed. Now scroll through the CTs, and this is how she presented to me acutely. You can see how the cup flipped over. And from the CTs from before and from the image here, you see you're going to have a large defect. This is at least 3A. She doesn't have a dissociation, but it'll be a big defect. I think Craig touched nicely on the when augments are needed. Usually when you run out of space, when anterior posterior, and you cannot go to a jumbo cup and you need to use some augments to supplement the area that's missing. I always tell my fellows that a jumbo cup and a cup with augments don't usually can be used in the same case. Cases that need that extra superior augmentation are usually cases you cannot use the jumbo cup because the jumbo cup will run out of space anterior posterior. So these are her pre-ops, and this is just a lateral of the femur, so the stem looks well. The stem could be well seated, but I always check the stem. These are the Judet films. You can see the different columns. We don't have a dissociation. This is a full femur that I always recommend when you're revising a hip. If you need to revise the stem, you have to know what you have left of the femur. The stem actually came out extremely easy. We didn't even have to work on it. We hit it twice to check it, and it just came out in the femur. So that made our life a little bit easier with the exposure. We didn't have to move the stem out of the way. A little bit of frenulinosis in this stem. And here you can see a reconstruction. Let me discuss what I did here. To emphasize what Craig said, the advantages of the REDAP cup, those screws which you have on the bottom for the ischium and the pubis are extremely useful. The thing I mainly look at when I position my cup inside is to try and put those two screws onto the ischium. So they'll match in the ischium, and I'll be able to get one or both of them in there. I also try and put screws in the pubis, and I try and use every other screw hole that is available. Not off-label, and it's not FDA approved, but you can also make new holes in this cup. If you have experience using other fully porous cups with a metal cutting burr, you can make new holes in locations where you think you can have good bone. In the REDAP, it doesn't happen often. You have 9, 11, or 12 holes, depending on the size of the cup, and usually I get all my screws. But in this case, you can see one of those 2 long screws was placed in a separate position that I had to drill through the cup. You can see the screws I put on the southern hemisphere. I think every revision should have screws in the southern hemisphere because usually revision cups fail in that manner. I added an augment here as well, a buttress augment, and I cemented the polar cup. So when I revise the hips, I look at the REDAP cup as reconstructing the acetabular, not as positioning a cup. So a lot of times my cups will be 50, 55 degrees of abduction, and they may be only 10 degrees of anteversion. But then I use the polar cup as Craig showed, and I cement that in the proper abduction and proper version. So I try and use the REDAP cup to get the best bony ingrowth, the best bony apposition, and then I use either the cemented poly or the cemented polo, which will give me a larger dual mobility head in the proper position, abduction, and anteversion. Here's also I used the REDAP stem, the monolithic Wagner taper 3-degree REDAP stem, which I find extremely useful in all of my revision cases. I think I do almost 100% of my revision hips now with this monolithic. I don't really find a lot of need for a bi-body stem anymore. You can see the Judate films. You can see all the screws. You can see the augment. You can see how the augment and the screws are perpendicular. The screws come in, and if you manage to put screws that actually touch and go in a perpendicular fashion, it increases the strength of the construct. Here you can see the screws in the posterior column and going up. Let's show another case. This is a 68-year-old female, 6 months after a left hip, 6 months of left hip pain. This is actually a very interesting case. It's a metal and metal total hip replacement. This is an X-ray from 2008. Nothing seems to be wrong. This is 2014. You still can see a good acetabulum. 2015, she had some workup for her spine. This is an EOS X-rays on, you can see on the left, and her pelvis. Again, the bony structure looks fine. This is in December 2015. And then 7 months after, she presented to me, and you can see the enormous amount of destruction that all of a sudden is apparent around her acetabulum and migration of her cup. Here you can see the Judate films. Her ischium is starting to disappear, as well as her pubis, and she has a big hole in there. She has a pelvic dissociation, and this is due to pseudotumor metal debris. You can see how the cup flipped. This is our MRI, part of our workup. Because this happened within a few months, we wanted to rule out the infection and tumors and any other thing that can cause such destruction quickly. And then the diagnosis was metallosis. And you can see here the usual tissue damage, the yellow colored tissue coming out. You can see the big metal head that was removed. You can see that debris, the really loss of area around, the huge defect in the acetabulum. Here you can see how I used the REDAP cup. You can see it placed. Some of the screws, as Craig said, the first screw I put a compression screw. I try to make sure it's a screw where the cup is sitting flush with the bone, so I won't tilt or change the location where I inserted my cup. Then I try and fill as many screws, and if I need to, off-label, I drill some other screws in different locations, as you can see in this cup. Here I placed a cage on top of that, and I'm about to cement a polar shell into this cup cage construct. This is how it looks after cemented in with a large dual mobility head. As Craig said, this location in these cases are one of their biggest concerns. So the ability to put a large head and the ability to cement the inner line or inner shell in a better position in these revision cases is extremely important, and it's a very, very efficient tool. Here you can see the post-reconstruction X-ray. You can see the cage and the screws into the pubis area, into the ischium area. I've recently been, when I use the cage, I don't insert the flange into the ischium. I find it challenging in these complex cases when I'm trying to position the cup in the best position. The whole idea of the cup cage reconstruction is that the cup is seated first with the best bony contact and secured with screws. The cage is augmenting or bridging the defect in the pelvic dissociation case in order to let the cup ingrow and limit the amount of micromotion or stresses that the cup feels. After the cup ingrows and becomes united with the pelvis, the cage is not doing much work at that point anymore, and that's why if this construct works, we won't see the fractures that cages see in long-term follow-up when the cage is used by itself. So what I do with the inferior flange now, I cut it a little bit shorter. I lay it on the ischium, I drill a hole through it, and I secure it with a screw or two. I'm sure that's off-label use of these cages as well. A third case, this is a 71-year-old female, history of staged bilateral hip in the late 1990s, done somewhere else. I was not an orthopedic surgeon at that time. She went 2 revisions in her right hip in 2013 for instability and fracture, had revision stem on the femoral side, had a cemented constraint liner and cage construct which failed on that Acetabular side. Have a look at her x-rays. She does not have peroneal leg discrepancy. And this is her current x-ray. You can see on the right where the cage has failed, and she has a pelvic dissociation. On top of the difficulty of reconstructing that, she also has the lumbar surgery in the past, which limits her pelvic lumbar motion. We won't go into that in this talk, but this is a very important subject for hip surgeons to start and appreciate the motion that the pelvis actually does in each patient and how does that influence the risk of dislocation. So some other x-rays, the inlet and outlet views, which the dissociation and the fracture line that you can see here very obviously. Some more x-rays, actually the cage itself, the two flanges on the cage, the superior ones are fractured in these two locations. And the patient has a well-fixed revision modular stem. Per the x-ray, it looks like we're going to try and retain that stem. We're going to check it intraoperatively, but if it's well seated and in a good position, there's no reason to remove it. It won't be easy to remove it. Preoperative imaging, you can see the area of the dissociation. You can see the large areas of osteolysis and loss of the acetabular bone structure. This is the reconstructions. Again, cup and cage construct. You can see the cup sit first. You can see the screws from the cup going in the southern hemisphere of the cup. You can see the screws going superiorly. I try and use every hole available. I think the more screws, the better. Length of screws also can usually be long, 45 millimeters. You can see the screw in the bottom securing into the ischium. And then again, cemented inside is the polar shell in a better abduction and anteversion position than the cup. In order to do the cup cage construct, you cannot put too much abduction into the cup. It will be very hard to fold the cage on top of that and get into the ilium. So that's the advantage of the ability to cement into this construct. One more case. This is a 84-year-old female, had toe hips done in the 80s. She had a hip that was uncomplicated until the last 6-7 months. She started developing right hip pain, some left groin pain, started requiring a walker, was getting worse, and she presented to us. Besides that, there was nothing unusual on her exam. She had a little bit of a limb length discrepancy on the left compared to the right. And you can see here the acetabular destruction on the right side, the complete polywear of the acetabulum. The head went through and starting to articulate with her ilium. Also on the left side, she has severe polywear, and she is a candidate in the near future for me to revise her left side. She's currently, in this case, being presented for her right side. I tend to get Jude in a lot of my reconstructions. I don't think that CTs are always needed. I don't think they'll change a lot of our surgical plan. They'll help us, they'll prepare what we need to have in the operating room, and they're very educational for our fellows and for our residents. So intraoperatively, the stem came out. On this case, if I go backwards, you can see there's a nice cement mantle, and sometimes in older patients, I may decide to cement into a good old cement mantle. So in this case, I decided I want to cement the stem back into the previous cement mantle. I would compare the sizes of the stems of the small synergy cemented stem compared to the stem that was removed. And this is the patient's reconstruction. Here, there was no need for a cage. There was no dissociation. You can see the redepth cup with the screws going into the ischium and into the pubis, as well as the screws going superiorly. You can see the cup is open around 50 to 55 degrees, a little bit neutral to slightly anteverted position, and then the polar cup is cemented inside in more of an abduction and anteverted position, and the new stem is cemented inside. The decision to cement another stem inside happened during the case when we're trying to remove all the previous cement and did not want to do an ETO. And as you can see, I left a little piece in the patient. One of our Oscars fractured while removing the cement, and it stayed inside. We discussed with the patient, and she was okay. We didn't attempt to do an ETO or more surgeries and moved it, but her previous stem was cemented, her new stem was cemented inside. You can see the location of the screws, and the patient is doing extremely well. I think this is my last case to present, and now we're going to be happy to take some questions.